Um, Thank you, organizers and the science committee, for inviting me here. And I'm really happy to have this opportunity to present our results from our new endoscopic surgery. Yeah. We have nothing to disclose except that I'm a neurologist, you know, and this surgery was performed by Dr. Kyung-Hoon Yang, who is here in this hall. So please find this guy and take your opportunity to give very difficult question to him, not to me. Okay. Mhm. So the background is that I opened the first CSF Leak clinic in Korea 2022, and I have encountered so many patients, which was never addressed by the other physicians. And in 2023, I was very lucky that Walter invited me to the Big Island meeting, which changed a lot in my practice. So soon after the Big Island meeting, I was able to start the ultra-fast dynamic CT myelography, thanks to Dr. Peter Krantz. He helped me a lot with this procedure. And this addressed my diagnostic unmet needs. However, I had so many patients so far, but although we became able to start the targeted treatment using the ultrafast imaging, so many unmet needs were left in terms of treatments because chronic SIH did not respond to targeted EPPs. So we wanted to get to find a neurosurgeon who do treatment for these patients, but our neurosurgeons were so busy in doing spine tumor surgery, and they did not want to do the dural defect surgery because they think it's way risky to do kind of spinal cord manipulation. So I was so desperate, but I happened to collaborate Dr. Kang Hoon Yang, who is one of a few spine endoscopic neurosurgeon performing thoracic spine surgery. Actually, we knew each other 20 years ago in medical school, but we haven't seen each other for the last 20 years. All of the sudden we got a chance to collaborate each other. We discussed about this disabling condition, and I was able to persuade him, and he established the novel endoscopic. Actually, there's not novel, but it's existing technique. But we started to implement that to our dural defect surgery. So today, my aim is to evaluate the efficacy and safety of this endoscopic sealing technique in our patients with ventral dural defect. So it's based on my prospective registry ongoing in our hospital, and we considered it eligible if patients with confirmed ventral dural defect, which was unresolved by enriched 3 ADPs. Uh, and they received the transforaminal endoscopic surgery. In this particular study, we analyzed the first 40 patients, but actually it's ongoing and the number is way growing. So we follow the patients more than 1 month. Actually, the follow-up was occurred immediately after surgery, and at 2 weeks and one between 1 and 3 months to find a final radiological remission. So we considered it successful if the follow-up imaging shows complete disappearance of the extradural fluid. So this is the surgical approach. You can see the uh, through this neuroforamen, and the endoscope can be approach the epidural space by gently widening the holes, the foramen by drilling it, and we can approach the ventral epidural space. And there we can find the hole and the causative calcification here. And we first remove it by gently drilling it. And we are confident that we completely remove the causative region because it's extradural procedure, not the intradural procedure. And we place the filling materials, first that taco seal and the layer plant, the artificial dura inside the dura, and place it again in the extradural space, like in sandwich mandible, double layered sandwich intradurally and extradurally. So there are artificial dura and taco seal. And some cases we put some gel foam here. So to summarize the sealing materials used, you can see the taco seals are used in all the cases, but we added layer plant, which is artificial dura, in from our ninth surgical cases, which we are now consider it crucial to place not layer plant added onto the taco seal, and zircon Terraform is not that mandatory procedure, but in patients who have very large extradural space, we put Terraform to keep all the sealing materials are fixed in location. So it's not the mandatory procedure, but it's optional. So you can see the video. Uh-oh. Can you play it? Yeah, we can see the calcification, and we dissect the between dry and calcification, and we remove calcification, and we can see the dural tear site, and place taco seal intradurally and layer plant as well, and do it again in the extradural cases. So artificial dural and taco seal, and some cases the gel foam. So that's it. So let's move on to results. The first result is the surgical findings that you can see the most of the leaks were located in the upper thoracic regions. And dural defect size ranged between 1 to 15 millimeters with an average of 5.6 millimeters. We were able to find the causative lesions in half of cases. Most of them were located in the ligament, not the disc. So ligament calcification was causing the leak. And cord herniation was noted in 6 cases. And sealing materials used included Tecofil, gel foam, and lye plant, as you can see here. And this is the typical response. This is you can see the large organized slag, which was unchanged over 2 years before surgery, and immediately after surgery, it has gone completely. And we follow the patients, and the disappearance of slag remained stable. When you look on the further details of the responses, uh, immediately after surgery, we found significant reduction or resolution of slag in 75 patients, 75% of patients, and half of them achieved immediate remission, and half of them had significant reduced slag. In these patients, they even they are not remedied completely. uh, 8 patients had ultimately remedied without any further additional procedures, but we wanted to see a very rapid improvement, so we implemented EBPs. You can see this orange bar. So we implemented additional post-op EBPs, and it helped. And this blue bar, you can see our redo surgery cases. In cases who did not show any resolution immediately after surgery, interestingly, 2 of them showed delayed response and ultimately remedied, and some of them underwent additional EBPs or additional surgery. So we wanted to see if this is really possible without reduced surgery. So when you define the success rate that is complete remission without reduced surgery, you can see the first few patients, our success rate from a single surgery was about 60%. Actually, at this time, we wanted to do it very safely without any potential complications because it was kind of first in Korea, and Kyung-hoon is a solo practitioner, and which is very prone to medical legal issue in Korea. So we wanted to it very very conservatively, but we became more brave and we added a live plant and we used larger live plant, which is sufficient to cover all the defect size. So now the success rate reaches about 100%. Uh, we found a very interesting thing in a patient who received repeated surgery. This patient had a very long ventral dural defect, and we replaced the taco seal and live plant as well. And after a few weeks, we did a repeated surgery because he had remained a small hole here. So it was very easily sealed by the second surgery. But what was interesting was that you can see here the dura looks like a natural dura, and it was artificial dura replaced here, but you can see very little neovascularization within the artificial dura, which may suggest a kind of dura regeneration. I'm not completely sure with this wording, but it's really interesting, and we were very thrilled about seeing this finding. So post-op complications do occur, but serious complications occurred in two patients, and none of them were left any long-term sequelae. And many of them were mild and the transient. There was no permanent neurological deficiency. There were three cases of transient limb weakness, which fully recovered after a few days. So to discuss efficacy, actually, these numbers are from literature, but I know in this horror there are very, very, very famous neurosurgeons do it more better than this literature. But we think our approach can provide comparable efficacy with the current state of the art surgery, with shorter time to remission and reduced operative time and potentially faster post-operative recovery because it does not require any laminectomy or durotomy. And the major complications were comparable between the two surgeries, and we use very minimal skin incision and minimize the bone removal. No need to do durotomy or dural suturing, and spinal cord manipulation is minimized. So our method offers a safe and minimally invasive approach through a direct access to ventral epidural space. Some of patients underwent additional ABPs, and it might have been unnecessary because there were some cases who should delay the remission without ABPs. However, it may have a role because it may have facilitated the sealing effect by utilizing like fibrins or fibroblasts in the blood. I don't know, but it helped or not. It's not completely clear at this moment. So far, we have 85 patients who underwent over 90 surgeries over the last 9 months. You can see the very big unmet needs, which was never addressed in Korea. So patients are very willing to receive this surgery. And among these 85 patients, 78 had thoracic ventral dural defect, which was treated by the transforaminal endoscopic surgery. And redo surgery was occurred in only 8 patients, and most of them were the first few cases. So no redo cases occur after our 23rd patient. And we have limited experience in cervical ventral dural defect, which was not feasible to do transforaminal endoscopic surgery, and which was treated by ADR or intralaminar microscopic surgery. And we have a few patients with post-operative puncture, and some of patients did not have dural defect, but he worried of thoracic calcification will cause dural defect. So he really wanted to do the surgery, so he did it. So the conclusion is that endoscopic sealing technique through transforaminal approach represents a novel, safe approach for ventral dural defects with high rates of success. And we think use of layer plant larger than the defect size is crucial for the success and long-term outcome, and the role of additional EVPs should be evaluated and are being evaluated. So I'd like to thank all of the collaborators in Seoul National University, especially Kyung-hoon Yang for this surgery, and our Korean colleagues and international collaborators. We are working on the international guideline on the optimal PAVI and ABP management. Thank you so much.